There we go.
So welcome everybody for joining. Today is our first DCAP academic seminar. In fact, official one of the year, February 2021, the strange year that we all see here. And I'm delighted to introduce you to a presentation by Dr. Simon Pickstone-Taylor. Simon is one of the honorary senior lecturers in the Division of Child and Adolescent Psychiatry here at UCT. And many of you will know that Simon very much is a national, if not international, expert in gender diversity, and has been an amazing honorary lecturer at DCAP, where he runs a program, but also an advocate for the needs and understanding the needs of gender diverse youth. So Simon, thank you for joining us today to talk about management of gender diversity, diversity in young people. I'll hand straight over to you.
Sure. Well, thank you very much. And I have in the past given a couple of talks now at DCAP and in other venues, and I hope that this can be useful for everybody, but I know each time there are people who haven't learned anything about this area necessarily. So please do use the questions, or feel you, if you want to direct a question at me, I'm happy to take those, write them down if you wish. And those that have perhaps heard this information, please feel free to ask whatever complex or non-complex questions you wish to ask. It is an area that for some people is quite controversial, particularly if you don't understand the facts. So please, nobody needs to feel embarrassed to ask questions that might be perceived as being perhaps prejudiced. Those are usually the most useful questions, and please, I just want this session to be useful for you. And also a bit of an update, although some of the initial material will be covering the basics, because I don't think anyone can understand this without understanding the basics. I'll also be moving on to more challenging areas and issues in the talk. Okay, so I'm going to be covering gender terms. What are we talking about when we talk about transgender? The incidence of transgender, how many of these young people are there? The causes, so-called causes of gender diversity. The diagnosis, I'm just going to mention briefly the changes in DSM and ICD, but I'm happy to go into more detail if anybody wants to discuss that or ask questions. Also, what co-occurring issues are there for these young people? And then most importantly, management, what do we do about helping them? And then also particular challenges or current things, which perhaps is a bit of the new stuff if you've heard quite a lot of this before. So for many people who work in this field, the genderbread person is perhaps even too simplistic, but for most of us, this is a good visual presentation of the four kind of main parts of gender. When I was growing up, it was very binary. You know, you were either male or female, and that was the end of the story. But we know scientifically that that is far too simplistic and not actually accurate for what we're seeing in young people. The sort of overall message is there's a spectrum all the way from one end to the other. And while most people do tend to fall into the poles of the spectrum on some of these axes, there definitely are people who identify or fall into somewhere on the spectrum. So the first axis is that I'll talk about is the purple line, biological sex. And while most people present as either male or female on the outside, there certainly are intersex kids. Please don't use the word DSD or differentiation of sex disorder. Intersex people hate being called a disorder, and that's not helpful. But I work with acrodyskia, with intersex kids, helping them and their families think through what to do about those situations. And actually thinking about intersex, I feel is quite helpful, because a lot less prejudice is in that field, as in most people feel, shame, well, let the child and their family decide what gender expression or how they wish to be. But actually, with gender identity, I think the situation is very similar to intersex, where the brain, as I'll get on to explain later, all the evidence is suggestive that the brain is actually one sex, so to speak, and the rest of the body another. It's just that you can't see the brain, that people start to have very strong feelings about what this young person should or shouldn't be doing and how they express themselves. But so even biological sex is on a spectrum. Then we get gender expression, which is also on a spectrum. 100 years ago, women wearing trousers were a disgrace and certainly not allowed in church, but I'm sure many of the female participants on this group are wearing trousers, and that's fine. And even if you go to your work in a suit, that's just more masculine gender expression, and it's completely acceptable usually. However, a man who wants to go to work, even to decap, everyone will be asking questions if he's wearing a skirt and how this will affect everybody. But it doesn't signify mental illness. It just is more feminine gender expression. And but for children, a more masculine gender expression, these are things like the clothes you wear, the toys you play with, if you play with boys or girls, that's called for a birth assigned female or girl would be called being a tomboy, which is a totally acceptable thing. However, a boy who has female gender expression is usually called a sissy or a morphe, which actually has more to do with sexual orientation. But nevertheless, you can sense the negativity that young people have towards boys who behave more femininely. And in fact, gay on the playground, as probably many of you know, is one of the worst slurs, but actually many kids don't even know really that it means homosexual, but they just know it's a nasty term. Then we have sexual orientation, which can be all the way from homosexual to heterosexual. Kids in school that call themselves bisexual are usually gays in the closet, or often gays in the closet, but absolutely bisexual people exist. And at schools increasingly now, I see teenagers are happy to be labeled homosexual and bisexual, and indeed are bisexual at school age. But I'm going to be talking really about gender identity today, which is the fourth axis. And for most of us, this is a pretty weird concept because we're born with a body and we feel okay with that body. And so we've never thought about the fact that maybe this body is wrong for us, or these sort of strange thoughts that people who do not feel in line with their body feel. And essentially, it's how you really identify inside. Do you feel male or female? And regardless of gender expression, as I say, you can be a tomboy and like to express yourself as a boy. It doesn't mean you're unhappy with your girl body parts. But gender identity, if you feel you're a girl and you've got boy body parts, you do not feel happy usually with those body parts. And very importantly, there's dysphoria about your body, but then there are also feelings about how other people treat you. And you want to be seen for your gender identity. That's a big thing for young people. So basically, the world treats girls and boys, men and women, very differently. And I don't think we quite understand that and the level of it, although some people obviously do talk, in feminist terms about how unreasonable things are. But if you feel you're in the wrong body, you feel that difference every day, and you want to be recognized and be respected for your gender identity. Okay, and genderqueer is not a nasty term. It's a term that some people use to say they believe they're somewhere in the middle of that spectrum. And young people use different terms and they will change. And you don't have to be scared of that. The important thing is to every young person, for instance, who I meet, I ask them, my first question to them is, what name and pronoun would you like me to use for them, for you? And also when they use a term, even like transgender or genderqueer, I always say, well, what does that mean for you? And usually I will, or pretty much invariably, I will say, well, listen, there's the spectrum from 100% male to 100% female. Where do you identify? And they will tell me, oh, well, it's 51% male or 70 or 90. Most of the people I see at DCAP feel they are 100% the opposite sex, but it can be somewhere on that spectrum in terms of gender identity. But please don't be scared of the terms. The terms I'm using are all non-pathologizing terms that generally transgender people are comfortable with, but they do change with time, and asking your patient how they like to be addressed and identified and understanding what that means. For some people, transgender might be 51% the opposite gender. For others, it's only 100% the opposite gender. So always discuss it with your patient. Gender diverse is a nice term because it reflects the spectrum, and most people find that also very respectful. Many people haven't heard of cisgender, CIS gender. That is merely what most people are. Their body is in line with their gender identity. So I think we've covered most things on that slide. So what's the incidence of transgender? It used to be thought as very unusual, 1 in 10,000 for transgender girls and about 1 in 30,000 for trans boys. Trans boys are birth assigned girls who identify as boys. We now think, and it's increasingly clear, that this is probably way too little. It's probably 1 in 200. And certainly I'm seeing that. When I started the service at DCAP, I saw maybe 1 in 6 months. And now I'm in a position where I'm getting sometimes 3 referrals a week. What's also happened is it just became impossible for me to see everybody at DCAP. So I've encouraged all of these patients want to be seen as soon as possible. Usually, particularly the trans girls who know their bodies are changing, and most of them present in teenage years. So I am seeing those that can come to see me in private, and because there is a bit of a waiting list at DCAP. And also what I've done is with Wendy's help and others, I'm now also seeing if they're from the Tygerberg catchment area. I'm seeing them there with their clinician. And yeah, so they're not as many, but don't worry, the numbers are increasing enormously. And interestingly, I just looked at this, and I'm trying to get the real numbers, but for a bit of research work that we did, which actually the numbers were completed early last year, I think, or before that, there were only 30 clients. I know now I've seen over 70 young transgender people. So you can see 2012 to maybe the first 8 years was 30 clients, and now I've seen 70. It really is taking off exponentially. We think the reason for this is the effect of the internet and media. Young gender diverse people are coming out all over the world at a much younger age. And I do always hasten to add at public meetings, but I give a lot of talks on this topic, that this doesn't mean you must rush home to switch off your internet. Your kids don't catch it from the internet. As part of the history I take, and I think this is an important thing to do, I take a very careful history of when the young person first had feelings of feeling they were different or their gender wasn't in line with their body. And invariably, it is always long before they went to the internet. With neurotypical children, as young as 3 years old, they can tell you they felt things were wrong if their memory goes back that far. And maybe age 7, they went to the internet and typed in boy who feels he's a girl, and up popped the word transgender. So they make sense of their gender identity and find terms and language for it after they have already felt those issues in themselves. And that is very valuable information to have got from your assessment to be able to share with parents. Because one of the parents' big fear is that my child caught this from being insecure perhaps and socially awkward, and then they joined the pride group at school and they were infected. Or they went on the internet and they spent too much time on the internet, so they caught it from YouTube. And it sounded like a nice thing, and it's totally unnecessary. Also, a high proportion of the young people I see have also Asperger's, something like 30 or 40%. And this is all over the world. So this becomes and they present differently. Most of them only develop an awareness of their gender identity in teenage years. So when puberty kicks in, suddenly that's when it becomes important. And for those parents, often they weren't unhappy as a child wearing a skirt or boys' clothes, whichever their birth assigned sex was, and only after puberty. And so those parents are even more worried. You know, this was a socially awkward child. Did they join the pride group, or did they spend too much time online, which, as we all know, many Asperger's kids do. They spend their lives online. So I have to help them unpick it and see that from the history, this child was having these feelings much earlier on. I've already mentioned there's a massive increase in referrals, not just at DCAP, but all over the world. And most of the kids are feeling they identify as the opposite sex, but there is, of course, the spectrum. Particularly with Asperger's, actually, the spectrum there is a lot more marked. So where does this come from? And for me, this is a very important issue in addressing and discussing with parents and teachers and, frankly, anybody who will listen. The reason for this is this particular thing causes a lot of suffering. It's nothing that parents did. In fact, psychiatrists used to think, rather like schizophrenia and then homosexual children, that this was due to overly anxious mothers and high expressed emotion and distant fathers. What they didn't sensibly look at is that most fathers in the West are pretty distant, so it's not such a good theory. But nevertheless, all the early research, pretty much all of it for the first 20 years, was on what the parents had done wrong to cause their kids to be gender atypical or transgender. And very pathologizing research, but it was very thorough. They looked at families, for example, that had 5 daughters, and the youngest one felt they were a boy. Did the parents, for some reason, want a boy and treat the child differently? All the studies show they could find absolutely no evidence for any difference in how they reared the child. Yes, today there are many parents who raise their children not wanting to be binary and only pink or only blue, but there is nothing in the histories yet, also myself, to show they push them in a particular direction. So basically that research is actually quite helpful because it conclusively tells us it is not environmental, as in nothing the parents did pushed the child to be transgender. And if anything, we know that transgender children have a huge push to make them be typically gendered, but it doesn't change their gender identity. So, you know, we know that half of the argument also. So where does it come from? Our first hint came from congenital adrenal hyperplasia, which is little female babies, XX chromosomes, who are being carried by women who have a much higher level of testosterone when they're in utero. Those babies are born with female bodies, slightly enlarged external genitalia, but they basically grow up to have bodies that are typical adult female bodies. However, a much higher proportion of them feel they're actually men. So that was the first time that doctors started to think maybe this isn't the parents just screwing up their children somehow. Maybe the brain is actually different due to different levels of testosterone in utero. And men and women have estrogen, progesterone, and testosterone. It's not like they don't have the typical other one. It's just the relative levels at particular times that change, particularly for pregnant women, that we today think probably is behind, at least in part, some of these young people being transgender. And people are fascinated in the differences between men and women's brain. There are many studies today on these things. We know least probably about the brain compared to the heart and the kidney and other organs, and still have a lot to find out. But there is evidence today in blood flow study, size studies, for example, that certain bits are either bigger or smaller statistically, depending on if you're male or female. The majority of the different parts of the brain that we do split up, there is no statistical difference, but there are some parts that are statistically either bigger or smaller, depending on whether you're male or female. And there's a typical female pattern brain and a particular male pattern brain in terms of sizes. That is relatively crude in terms of what that means, but nevertheless, it's statistically significant. And guess what? If you take a group of transgender women's brains, they follow the typical cisgender woman's brain pattern. Now that's huge, because that's telling us statistically that if someone says, listen, I've always felt my body is wrong for me, I'm the opposite sex, probably their brain, with the best science we have, is the opposite sex. And they're also studying blood flow in males and females and connectivity, and early evidence is showing the same thing. Now, some parents do, once I tell them that, they say, well, that's great. Can we now do a brain scan on my child? And then we'll know for certain what you're saying is true. The answer to that is unfortunately or fortunately no, because it is a Bell distribution. So even the father of the child might be a 5% outlier and have a more female brain pattern. That doesn't mean I now tell the father he must have a sex change in order to be happy. He knows what his gender identity is. We all do, hopefully, know if we're comfortable with our bodies, and the majority of people are happy with those. And you don't need a brain scan. It would be very expensive, and I don't think we have the necessarily the skills, even if somebody had lots of money, to be able to do that locally in South Africa to say, is it the typical male or female pattern? But actually, you don't need that. You just ask the child, and that is what's important. But for some people, the brain scan stuff is very helpful because they like concrete answers. So now touching on the DSM and the ICD, essentially the general trend here is to move away from pathologization, and both of the categorization systems have tried to do that. The DSM, though, is American, and they only have mental health diagnoses. They don't have other things like pregnancy and all the other physical ailments. So they've moved it to a new chapter of sex and gender a new chapter rather than of sex, rather than gender disorders. And they are now separate from sexual dysfunction and paraphilias, which they used to be in DSM-4. No one wants to be part of a sexual dysfunction category. And they talk about gender dysphoria instead of gender identity disorder, which is a little complicated because some of the young people I see don't necessarily have gender dysphoria. That is the sort of feeling of real uncomfortableness about one's own body. Most of them do, but some of them don't. So some of them wouldn't necessarily make this criteria, which brings up a whole spectrum of issues. But most do have dysphoria, and at least that sounds a bit less pathologizing than disorder. But But they have continued to give in DSM-5 children a pathological diagnosis, which is very controversial because many people, including myself, who work with these kids, feeling they're exploring, getting to know understand their gender identity and sexual orientation and all these things, and they don't need any interventions in terms of hormones or surgery, as I'll explain shortly, and pathologizing children with a disorder or a diagnosis when actually it's the world around them that needs the help is not necessarily a helpful thing to do. But I'll talk more about that if anyone has any questions or interests. So in terms of ICD, which has been coming for a while, the ICD-11, the WHO owns this, and they've had the ability to move it outside mental health, which has been very helpful because in some parts of the world, transgender people have been imprisoned on the basis that they have a mental health disorder or put in a psychiatric institution against their will. And they have instead used the term gender incongruence instead of gender identity disorder. They have, however, also chosen to continue the child diagnosis. And just to remind you that things like pregnancy are in ICD, which is clearly not a disorder. So ICD is also less pathologizing. So what other problems do these young people have? Well, particularly younger children, not just transgender younger children, but they present with headaches, tummy aches, things like that. They won't tell you what the problem is or have emotional and behavioral problems. School refusals, you should always be thinking, is this child perhaps gay or transgender? And that is why they don't want to go to school. So just popping in very non-emotive but simplistic and direct questions is a good thing to do. Even if they don't tell you the truth the first time, they will know by the way you talk about this area that it's a safe space to talk about it. But certainly as things go on, full-blown anxiety disorders and particularly depression become major concerns. Essentially, the literature shows that if these young people aren't adequately supported, 50% of them will have attempted suicide by the age of 18. And in my understanding, we have nothing else in terms of child psychiatry, where a relatively circumscribed group of people, 50% of them get so distressed and so depressed and unhappy that they try to kill themselves. And that number has been questioned, by the way, by some people in quite high authority. So I took the trouble at the end of last year to go and look at the literature again. And I did find a study from last year, quite a big study, which showed exactly that. 50% of these transgender and gender diverse youth had tried to kill themselves. And as is logical, this is due to the response of the world around them. If they are appropriately supported, things improve radically and very quickly, usually, particularly in children, sometimes not quite as quickly in the teenagers who have clinical depression, but things usually within a month or so are markedly better. So what do we do about all of this? How do we actually help these kids? Well, originally psychiatry used to view this as a disorder, and understandably, in my view, they would try to change these children's gender identity. And I must admit that if you could give therapy that would make young kids happy with their bodies, and their gender identity in line with their bodies, I think there would be a very strong argument that that therapy should be allowed. However, all of the science has shown, and the studies, that you cannot change a young person's gender identity. And all of those kids, exactly the same proportion, grow up to still feel they're transgender, Kids aren't stupid. If they're there for week after week of therapy trying to change their gender identity, they will fake it and tell the therapist, partly to get out of therapy, because they generally hate this form of therapy, that they are now cured and cisgendered. And the same thing happened with gay and lesbian kids, because they want people to accept them and respect them. But basically, it doesn't work. And in the future, just as many are all saying they're still transgender. And particularly from Tanner stage 2, there's no argument about that. There are 5 stages of puberty, but from Tanner stage 2, if a young person is saying that they are transgender, it is pretty much never going to go away. Certainly 90% plus will continue to be transgender as adults. It doesn't matter what therapy you do with them, it's not going to change them. And there are movements all over the world at the moment to outlaw it. It's a form of reparative therapy, either for sexual orientation or for transgender. And yeah, I certainly don't think anybody should be. There is still, unfortunately, religious fundamentalist groups do still try and do this. But yeah, what we really should be focusing on is best evidence guidelines for how to help these young people. And there's an organization, the World Professional Association of Transgender Health, or WPATH, and they have standards of care that pull all the evidence from all the scientific work on these kids and what is the best way to support them. And right at the moment, there are a number of committees all looking at the different parts of transgender health to bring out version 8. So within the next year or two, I expect version 8 to be out with updated guidelines. And this is a controversial area for many people. So I think while in any part of medicine or mental health, we should be looking at good, solid evidence, I think it's not just a matter of making these recommendations. It's important to tell the parents that actually everything I'm saying or you say to them is coming straight from the guidelines and evidence-based medicine. Because parents don't want to know that your opinion based on the last 3 patients that you've seen. They want to know that this is good, backed up by science, because it is a big thing to be making the suggestions that the guidelines recommend. Yeah. So what does it say? In terms of pre-adolescent children, usually junior school children, they just need a social, well, firstly, the families need psychoeducation and support. And that is done in the first evaluation. I was relieved to find that you could do all of this work in one sitting. When I came into DCAP from the wilds of the Boerland, I was very anxious about having to come back for 7 sessions. But actually for 80–90%, one big session of 3 hours of first evaluating the young person and seeing them alone and with the parents, getting everybody as part of their history. Very important to do an objective assessment, even if I can tell from just seeing the child walk in the room plus knowing the history, I still ask all the questions and go through it all methodically in order to be able to answer the parents' questions and concerns truthfully. The second part is the psychoeducation, which is saying, the second part is feedback. What I'm seeing, which is basically invariably, yes, I do believe your child's transgender, and given that they passed Tanner stage 2, this is unlikely to change. Then I do the third part, which is what shall we do about this? And very important, to make clear to the parents and the young person that all the decisions, all the changes are their decisions. I don't, and none of us should be making decisions for the family. Hearing that message usually is very helpful to families, because then they feel they're not going to be railroaded into anything. And I do support changes at the speed that the particular family is ready for. Most of them will say, gosh, this is a lot to think about, but I can see it's really important for my child and their future happiness, and I am going to take some time to get used to it, but I am going to support all these things. Some of them do say, I want to, let's come back in 3 weeks and talk about it then, because it's been such a shock. We really didn't expect this. But having a professional do a thorough assessment helps a lot of parents come to terms with, this is actually what's going on. We were always worried it might be this, but now we do need to move on and to get help psychologically in coming to terms with it, or whatever they need to do. The children themselves just need observation and support. They don't actually need 10 sessions of therapy. I haven't referred one single child, adolescent child, for any form of therapy. I don't think, because it's just the environment that needs to be adjusted, which is also wonderful given we're South Africa. At the Tavistock, they have a waiting list of something like 2 years. So actually, the DCAP waiting list is incredibly short, as well as my private practice one, because the Tavistock makes them all go through loads of assessments, and actually the work can be done in one session. And time is of the essence, particularly with teenagers. So I would say, ironically, with a lot less resources, we have a much better system of doing this in South Africa. And also similar work is done in other parts of the world to what I'm doing. But the controversial bit is these young people should be able to express themselves as much as possible, including at school, or a social transition. Essentially, a social transition is all the obvious stuff about how they identify as the opposite gender: name and pronoun, school uniforms, toilets, changing rooms, and sports. And it is important not to assume, I think you're transgender, so you must change all 5 of these things at school or at home. It's very much should be led by the child themselves, what changes they feel up to. They might only want to change their name and pronoun in a young child and see how things work out. And very important to be respectful of where the child is and what they want. So it's very important that they should be asking, in fact, demanding these changes, which they usually are. And then our role is also to talk to the schools and to facilitate a social transition. And we have over 40 schools now in and around the West Cape Town and the Western Cape, where social transitions have occurred. And I can talk in more detail about how one does that, but I do think it's important that mental health workers working with these kids should be prepared to do that. At this time, it still is a controversial thing, but I'm pleased to say Ron Adenal, who started this work and still does it alongside me, just depends who's working with the family or child. Between the two of us, we have over 40 schools now where kids have socially transitioned, not one episode of significant bullying. But it is important that it is rolled out appropriately. And we first phone the principal, tell them they've got a transgender child, say, would they like some help? They need a social transition. These are the things the child wants. Invariably, they do want some help. They're terrified often. And then one of us gives a talk to all the teachers in the school, which I think is only respectful, so that they understand. And then we help them with a brief of how to talk to the parents, and then lastly, the children. And children get this. It's not a major issue for them. And as I say, not one episode of bullying in all these schools. The outcome for children is remarkable. Once the school or the family accepts their child's gender identity, whatever comorbid problems they had, along with a variance in gender identity, it disappears the same day. And really, it's incredibly gratifying and heartwarming to work with these families because it really disappears the same day. And it's almost a way of knowing, was this what's going on? So kids that for years, their parents thought it was a tomboy that was very oppositional, fighting with other kids at school, constantly unhappy, nagging, irritable. The same day, that child becomes a wonderful, cooperative, loving child, and all the problems at school disappear. So what do we do for teenagers? I haven't seen any questions popping up, so I'm just steaming ahead. Please tell me to stop and take questions if anybody has any, but you're also welcome to keep them until I've finished, which won't be forever. So what do we do for teenagers? Teenagers have this problem that their bodies are going in the wrong direction. Now, even normal puberty in the right direction can cause many teenagers to feel very insecure and even want to kill themselves. But if you're a guy and you're growing breasts, or you're a girl and you're growing, your voice is deepening and you're growing facial hair, it is deeply disturbing. And it is not surprising, if you think about it, that so many end up feeling suicidal over this. They can't even tell their parents usually. And if they do feel brave enough to tell anyone, their friends or family say, well, this is puberty. Yes, you feel a bit awkward, but you'll get over it. And there's nothing we can do to help. So they feel hopeless. And in the end, many want to harm themselves. As a result, in the past, the treatment for teenagers used to be that you had to wait until you were 18 before you could get any hormones or have any surgeries. Now, and that's very logical because, doctors are very conservative people and no one wants to help a child make big changes, particularly that are irreversible, if they might regret it in the future. However, some very important facts led to people trying something else. The first fact I've already told you is that 50% try and kill themselves if they don't get help before 18. The second fact that many people don't think about is that most people who do have to wait for 18, and people my age and older transgender people, did go on to get hormones, but later on in life, when they could afford them, in their 30s and 40s. And by that time, their bodies have already changed with puberty, and it is actually very hard to change a body back or change it into the opposite sex. And they hang in there, they get their hormones and the surgeries, but once they have finally had everything, about 50% of them don't pass as the opposite gender. They look somewhere in between. And that has a very poor outcome. If you look in between, and I have a teenager at the moment who looks in between because they've started hormones, strangers on the street shout abuse, morphe or tranny, or say things like, that's despicable. How can that person do that on moral grounds? Or even a very well-meaning person will ask them in the supermarket, have you got a penis or a vagina? The same person goes home and is devastated that they asked a complete stranger that question, but we become disinhibited when we see something we don't understand, and perfectly nice people ask really inappropriate questions. And if you're the transgender person to be barraged by those questions every single day, or worse, abused on the street, it becomes pretty overwhelming. So if the unlucky enough 50% who do not fully pass because you only had these changes later, 40% of them, of the total transgender adult population, try and kill themselves. So we have one of the worst prognoses. 50% by 18 have tried to kill themselves. And then for those who get the changes later, 40% try again. Because of that awful prognosis, a Dutch clinic started to offer firstly hormone blockers to these kids once they had passed Tanner stage 2. And they knew from the literature then already, which hasn't changed, that once you enter stage 2, 90% plus are never going to change their wish to be the opposite sex. So what happened was that alone was life-saving. Kids won't kill themselves anymore once they are on hormone blockers. As long as these boobs aren't going to get any bigger, and they're not just man boobs, they're serious breasts developing, or the voice isn't going to break, or the body facial hair isn't going to get any worse, these kids won't kill themselves. And I see that in Cape Town with kids who come straight from inpatient units, and they've finally shared with somebody it's got to do with their gender. They will not kill themselves if they're on hormone blockers. But then they had a problem. Do you then force these kids, some of whom start on Tanner stage 2 by age 11 in birth-assigned girls, to sit on hormone blockers till 18, while all their peers go through puberty, which is not a great thing to do. You want to be dating and doing all the usual things, and most of these kids will not date or certainly not be physical until their body is more in line with their gender identity. So they started to give cross-sex hormones aged 16. And the outcome of them were even more remarkable. If you're given the cross-sex hormones early enough, you cannot tell the difference. So physically, they completely passed as the gender that they identify as, if they get these hormones early enough and they haven't gone through too much of puberty, been on blockers if necessary. And that is because what we're looking at is things like body fat distribution and hair when we make decisions about is somebody male or female. We're all incredibly good at judging in under a second with a high degree of accuracy without any training of us. All people can pretty much tell if someone's male or female. And that's what these young people need, is they want people to respect them for the gender that they feel they are. And so 100%, I'm just going to jump to that slide. The changes the hormones make are things like body fat distribution, which is what you see, the hair, the voice, all of those subtle things, not actually genitals, but you don't see genitals when you make that decision on somebody's gender. And the outcomes are that they are very happy. Their mental health level goes to a well-adjusted baseline for their age. And very importantly, number 3, none wish to go back to their birth-assigned sex. Now, you will in the press or on the internet see 1 or 2 occasionally highly publicized cases of people who did want to retransition back. However, usually what those stories do not tell you is that the child or the young person is actually totally okay with what happened, that they are on their gender identity journey. And maybe 5 years, 10 years later, they want to stop taking testosterone and see how they feel. But invariably, they don't actually regret what happened, which of course the press doesn't tell you. So a very small percentage might choose to stop taking hormones later, but compared to the vast majority that have really happy, well-adjusted outcomes, passes the gender that they feel they are, and have no regrets whatsoever, I think the risks far outweigh the benefits, far outweigh the risks. Just to tell you 2 points that are particularly important for South Africa, hormone blockers, unfortunately, are very expensive. About 5,000 Rand an injection. Usually you need every second a month. Fortunately, you only need that for a period of time, though. If you're on no medical aid and have no money, the endocrinologist can get you those free, which is unbelievable in my book at Curtis Skier. But the cross-sex hormones, which you will need for the rest of your life, are a lot less expensive. Testosterone, I believe, can be about 150 Rand a month. But obviously that's an issue. And if you have any money at all or any health insurance, you can see the Curtis Skier endocrinologist for a lot less, but you do have to pay for your hormones. At this point in time, Discovery is just starting to have some tiers that they will cover transgender health costs for, but it's still early days, and this is a major issue for some families. Overseas, like in the States, most health insurances completely cover these things because they realize an inpatient admission for 2 weeks costs, well, in South African terms, 75,000 Rand, whereas giving the hormones, you have a much better mental health and much better outcomes, longer term or even medium term.
Yeah.
So I'm going to talk now in kind of more general terms about what we should be doing. Firstly, we're not a gatekeeper. Unfortunately, mental health has a very bad history in terms of working with transgender people. For instance, at the Charing Cross Clinic for adults, if your outcome was homosexual, and just to explain this, if you were a transgender woman, so you were a birth-assigned man, but identified as female, and you told them in their intake that you were attracted to females, so you were going to be a homosexual transgender, they wouldn't let you have the hormones or the surgery. It had to be a heterosexual outcome. And so these gatekeepers, psychiatrists and psychologists, became gatekeepers. And not unsurprisingly, all the transgender people would tell each other what to say in the queue in order to get their hormones and surgery. Because we know today there's a lot more diversity in sexual orientation for these people, for transgender people. And there's absolutely nothing wrong with being homosexual. So yeah, there's a very bad history of mental health people being very restrictive, and even more so to children, pathologizing them and giving them really horrible therapies. So I found, for instance, a year or so ago when I went to Canada, and I'm used to generally in Cape Town, young people liking me and engaging with the minute, you're gender affirmative, there was a lot of suspicion in the groups I was in at a particular conference because I was a psychiatrist. Psychiatrists were seen as really the most dodgy people possible, who generally, even in Canada, were seen as restrictive people who are gatekeepers. Really, our job is to do a proper assessment and to make sure that the young person has optimal mental health and that they have the supports they need, that their parents have the psychoeducation that they need. We address their environment in terms of schools, and then very importantly, if it is appropriate, refer them to the endocrinologist. Now, one of the things I do is a detailed psychiatric assessment. It's not magical, but not just transgender, but also background psychiatric, a general psychiatric evaluation, and I write it up in a report. And the very helpful members of DCAP who have sat in with me and since last year have been helping me write these reports are learning how to do that. But it's not that complicated. It's what hopefully you've learned to do anyway. And this is an important document because when they go to the pediatric endocrinologist, they will need that report. The WPAS standards of care say that we should work in a multidisciplinary team, and before seeing the hormone person, particularly if you're under 18, the endocrinologist doesn't want to assess, do you really have transgender and are there other problems? Our job is to sort that out, and they arrive there with their nice report, or it's already with the endocrinologist. And there are people in private as well as state who I can refer them to. In terms of demographics, I've seen people as young as 3. Gender identity develops between the ages of 2 and 3, sexual orientation between the ages of 7 and 8. So it's a very early thing. I've seen every race. I do see far more white people, particularly in private practice, because they have access to healthcare and they hear about me, and every socioeconomic group and every religion. And very importantly, I'm seeing loads and loads of autistic spectrum young people, particularly, well, the high functioning particularly, about 40% it feels like. I don't know when I last saw a neurotypical child, it feels like. Yes, I do see them. Initially, I was worried about this because I work for the neurodiversity clinic, and I thought maybe I was overdiagnosing, but there are reports from all over the world. I think Finland had the first reports that showed a much higher incidence, but this is well understood now in WPATH, that there's a huge overrepresentation. We don't understand why this is. It's a very interesting co-occurrence, and we can talk about that. But the bottom line is I can't really tell parents why. But the kids I see, for instance, in private practice, they do go on to have a disco or a diagnostic assessment, and invariably they confirm what I've seen at my assessment. Current challenges, as I said, is, for instance, the autism. There's a high percentage of Asperger's, and really these young people are not interested in their Asperger's often, they just want the hormones, even though they are very socially isolated. And actually, in my view, that is just as important as the hormones and their gender issues. And the resources are not that good always, or being able to afford them, for actual practical work and interventions and therapy around their autism. But I do make a meal of education around autism. Also, they're gender non-binary young people, and what they want often differs. They want to be me to use the terms they and them, which I'm much better at now, but the first 2 reports with they and them really was a nightmare. There's nothing like having to write an 8-page document with they and them, but strangely by the 3rd one, it was absolutely fine. So these are hurdles you have to get over in your mind. The older you are like me, the harder it is to change your wiring, but you can get there, I can assure you. I've talked about the cost, the insurance.
Sorry to butt in. Just to say that we've run out of time and people are starting to leave. So maybe if you could perhaps just in the next minute or so, just give us key messages or wrap up. If anyone then wants to stay on for a minute to ask questions, but I'd rather do that than have people run away and not have a chance to get to the end of your presentation. Sorry about that.
Yeah, I'm very sorry. I thought we went on till 12. I didn't realize it was just a 1 hour. I've got my wires crossed. But fertility issues are also now with advances. Eggs can be harvested, and I refer them to Vincent Pilati, but they have to have the money. And certainly sperm donation, I recommend that. Lastly, there's the world of science and the wars around that. And it really is quite frightening. I'm part of an international group that tries to debunk fake news. And there are Christian right-wing groups who literally sponsor research that will try and prove non-WPATH guidelines true. I'm just going to give one example. There was an ultra-conservative Catholic website that published a study or a report of 63,000 deaths in America in 1 year due to Lupron, which is one of the hormone blockers. Of course, what this report didn't say is that terminal cancer patients take Lupron, and every single one of the 6,300 was a terminal cancer patient and not a transgender child taking hormones. But the damage is done with fake news, because once the concern is out there, they don't have me or someone else to explain them. The anxiety there, and it creates a lot of negativity. And I can talk about rapid onset gender dysphoria or autogynephilia, there are various things that have been raised that are very unscientific, but cause considerable concern, even for patients here in South Africa. I had 3 parents who came in on the rapid onset gender dysphoria paper. But generally, I think the take-home message is not to be scared. You will definitely come across transgender youth in the future. If you're part of DCAP, please come and join me for one assessment. I'm very happy and have really enjoyed doing these assessments with people in DCAP. It's not often we get to share spaces and do this. And these young people are incredibly resilient. They are doing so well in their schools. And one school who's had one transgender person, once the work's done, you don't have to reinvent the wheel. It's a bit like having a Black child in the school accepted. Once the policy's there, there's no going back, and it's a complete non-event. Anyway, that's more than enough from me, because I still thought I had half an hour to answer questions. So I'm ready to do that, but to take any questions now. Thank you.
Thank you, Simon. And maybe you can stop sharing your screen.
Okay.
Lovely. And I'll ask John Joe to